Bom dia a todos. Vamos começar a nossa apresentação mais esse sábado no For Valves TV. Hoje é uma apresentação especial que acontecerá em inglês. Good morning, everybody. We are again here in our For Valves TV channel. Today we have a special transmission and the chairman will be Dr. Vinicius. Vinicius, please. Your mic is off.
Bom dia a todos no Brasil. Como o Márcio nos disse, hoje a gente tem uma sessão especial. Obrigado por se juntar a todos nós aqui no Brasil nesse sábado, 9 da manhã, e a apresentação será feita em inglês. Hello, good morning to all from Brazil. Thank you so much for joining us in this Saturday morning. Good morning, Professor Horst Sievert in Germany. Good evening to Dr. Liu at China. I'm Vinicius. I'm here in Goiânia at Anisras Hospital, and today I'm going to be your host, the chairman of this event at the For Valves TV. I must say that I'm honored to be here. Thank you so much, Gustavo, Márcio, and all the team from the For Valves TV for this invitation. Congratulations for all that you have accomplished and achieved in the community and structural heart disease here in Brazil and also in Latin America. And to be a hard task to be here at Márcio Montenegro place as session coordinator. Márcio, our showman and multi-language presenter of the channel, and today will be my co-chair. So today we have a special morning, the launch of the VenusA transcatheter valve from Venus MedTech. First of all, in the name of all For Valves team, I would like to thank to OMEC company, in the name of Vitor Hugo and Rafael and all the team, and for the support of this event. As one told me, probably the VenusA valve is going to be on market at Brazil in mid-July, just a few days, after all effort of the OMEC team. And today on the panel, I have two very experienced operators in TAVI from Brazil, especially in self-expanding prostheses available here in Brazil, Evolute, Curate, and Porico, who's going to share their thoughts about this new device. First, our friend from Northeast, Eduardo Pessoa, from Recife, who's interventional cardiologist at Rede D'Or, São Luís, and Procap and the Universidade de Pernambuco. And from South, Rogério Sarmento, from Porto Alegre, our great friend and one of the pioneers in TAVI here in Brazil, and also very experienced in self-expanded prostheses. And at last, Márcio Montenegro, who all you know from Rio de Janeiro, and who has a lot of experience with TAVI as well, since the time of the first generation of core valve. Finally, you have two special guests. We have the two presentations, Professor Horst Sievert, whom we all know from the CSI Congress. He's the director of the Cardiovascular Center, Frankfurt at Germany. And the other special guest is Dr. Liu from China, who's going to present us their experience with VenusA valve in China, especially in bicuspid valves. So without any further delay, Márcio, I would like to call Professor Sievert, who will tell us about the design, special features and results, and some case examples from the VenusA valve. Professor Sievert, please, if you can start your presentation.
Thank you very much, and thanks to the organizers for inviting me. Let me just go to this screen here. Do you see my screen now?
Yes.
Okay, yes. So my title is the VenusA valve design, special features, results, and some case examples. So I think many of you already have seen this valve. It looks a little bit, looks like the core valve to some degree. It has a self-expanding frame. It has a porcine pericardial valve. It has, like the core valve, supraannular leaflets. It comes in diameter 23, 26, 29, and 32 millimeters. It is 19 French, but it can be used without sheath, like the new generation of the core valve. So it's kind of 14 French comparable when you look at the outer diameter of that sheath. When you compare this to the Evolute valve, well, the advantages are it has a higher radial force, and I will show you some examples for that. In my feeling, it has a more stable deployment. It has some position markers for easier placement, and I will show you this as well. There's also a disadvantage, and that is the current version is not retrievable. And there is a new version, the VenusA Plus, which is already approved in China, but not yet in South America. By the way, both venous valves are not approved yet in Europe. So this shows you a series of images in one patient, and you see this little marker here, which is at the lower end of that pigtail. And now we start deploying this valve, and you can see it's absolutely at the same level all the time until the final release of the valve. And that is something which I haven't really seen with the core valve. The core valve is always moving down when you implant it, but this one is really stable. And I think this has to do with the delivery system. It's not a feature of the valve. I mean, the markers, of course, a feature of the valve, but the stability is because the delivery system of the venous valve is more stable than the delivery system of the core valve. And then I already mentioned it has a high radial force. And why is that important? You can see an analysis of the calcium content of valves, of native valves, of course. And you can see the calcium content in China is much higher than the calcium content, for example, in the United States, also in Europe. Actually, Western China is in between. I don't know the situation in South America. I'm assuming you are more like the Americans or Europeans with low calcium load of the valves, but it's good to know that these valves can handle these severely calcified valves. And you can see, for example, the difference in radial force for the 29 millimeter core valve compared to the 29 millimeter venous valve. And here is the 32 venous valve compared to the core valve. Here's no difference. That has something to do with the model, how they test this. But here the 23 again, the venous valve has always a higher radial force. And I will show you an example why this is important. When we started using these valves in the early days, I think that was around 2012, we had the first generation of the VenusA valve, which is not available anymore, which had a radial force like the core valve. And you can see in a patient with really severely calcified valve, even after balloon dilatation, the valve didn't even open here. So we had to retrieve it and do something else. So this is something we learned from these early cases in the early days, 10 years ago. And then the second generation of the VenusA valve, which is the valve which is currently available and used in China and now in South America, that has this higher radial force compared to the core valve. And here you can see another example of a heavily calcified valve. And now you can see that this valve's opened up after implantation. I mean, when you look here, it's too deep, and this is another issue. I think we will hear in the next presentation how to overcome this issue. But at least you can appreciate that this valve now has a higher radial force than what we used to see with the core valve. This shows you, again, second generation of the VenusA valve, which is the currently available valve. You can see the pre-dilatation here, and then you can see the deployment. Again, it's implanted too deep for sure, but it just shows you that these valves open up with higher radial force than with the core valve. We had some cases with very eccentric annuli. This is a tricuspid valve, but very eccentric here, and you can implant this valve here. You can see the compression, but it works well and had a good long-term outcome in this particular patient. We did a trial from 2012 to 2015 in more than 100 patients. You can see the baseline characteristics of these valves. 97 had been native valves, 4 had been valve-in-valve. You notice a very high rate of bicuspid valves, and that is because many patients in China have bicuspid valves. Why is that important? You may say, okay, we in America or in Europe, we rarely see bicuspid valves, but we are moving now towards a younger patient population, and we know from many statistics that younger patients more often have bicuspid valves. So here the mean age was 75, so this is something which is very specific for China, but it's good to know that with these valves, bicuspid valves had been treated. And you can see again some data about the incidence of bicuspid valves. These are in the Venus trial was 33% of the valves had been bicuspid valves. And this is, in reality, this is even higher than that, because initially when we started that trial, we excluded patients with bicuspid valves. So the real incidence is higher. Here are data from France, 9.2%, from Paris, 4.7%, the German TAVI registry at 2.7%, and the SDS TVT registry had 1.6% of bicuspid valves. The different thing which is different in China than in Europe is the diameter of the femoral artery. In China, we had a mean diameter of 6.4, whereas in other areas of the world, it's more 7 to 8 millimeters mean diameter. This was the type of anesthesia at that time. Many procedures had been done in general anesthesia. Today, I think this has changed, and we in Europe here rarely use general anesthesia at all. I think in China this has also changed over the years. When you look at the access, and here comes back the fact that many of these patients have very small femoral arteries, and that's why in 14% we use the transaortic access, and here you can see right in left femoral artery, not important, but this is the point here, 14%. We could not use femoral access, and we used direct aortic access in these patients. Valve size, you can see that the smallest size, 23, which we never use in Europe, had been used in 3%, and then 53%, so the vast majority at 26 millimeters. So in Europe, I think the average size we use for the core valve is about 29. So this shows again that the anatomy in Chinese patients is in generally smaller than in European patients. These are the results of the VenusA trial. The results had been split between bicuspid and tricuspid. You can see that at that time, the results with bicuspid valves was a little bit less good than with the tricuspid valve, but overall the results had been reasonably good, if not good, compared to the data with other valves at that time. 2-year survival rate was 90%. This shows you the mean gradient. There was actually no difference between bicuspid and tricuspid valves. This shows you the improvement in clinical status in heart failure class. This is something we know from all other valves, of course. And this is the clinical outcome at 30-day. When you compare the results, they are not as good as today, but they are absolutely at the same level what we had with other valves at that time in Europe and the United States. So overall, a good outcome in these early TAVR days. So does this valve have good long-term results? This is the follow-up up to 5 years with this valve. You can see the mortality was 21%, which is again comparable to all other valves. At that time, stroke rate overall to 5 years was 4%, which is not very high. It's actually low. Surgical intervention for any reason, 3%. And then new pacemaker was actually compared again to the data at that time with core valve was very low. And that was a little bit surprising because we, as discussed, this valve has a higher radial force, but still the pacemaker rate was pretty low with 20%, which is less actually at what we had at that time with core valve in Europe. No valve thrombosis, no endocarditis. You can see the mean gradient and the mean valve area remain stable up to 5 years with this valve. And this shows you the degree of aortic regurgitation. We had more mild regurgitation than with other valves in Europe, and that is due to the enormous calcium load of these valves. But you can see there was no significant change over time up to 5 years after the procedure. We looked at the structural valve deterioration defined as mean gradient at any time of more than 20 but less than 40 millimeters of mercury. That happened in 5%. Change in mean gradient from discharge, 1 month of more than 10 but less than 20 in 3, and moderate central AR occurred in 5 patients. We had no severe hemodynamic structural venous valve destruction in any of these patients. The new version, the VenusA, has a retrievable sheath, and we will hear more about in the next presentation. This is now approved in China, but not yet in South America, as understood. This will be available in a couple of months if that information is correct. So my take-home message is results with the VenusA valve are comparable to core valve Evolute. It's superior in heavily calcified valves, and it has excellent long-term results up to 5 years. And the new VenusA Plus valve is retrievable and will be available very soon in South America, as it is already available in China. Thank you very much for your attention.
Thank you so much, Professor Sievert, for the excellent presentation. I'm sure it was an honor for all of us here to be able to learn a little about the VenusA valve from you. So now if you can hear some considerations from our panel, Eduardo, Rogério, do you have any question for Professor Sievert, or do you like to make any comment?
Yes, first of all, thanks a lot of invitation, Márcio, Gustavo, Paulo, and all team of For Valves. It's a big honor and a pleasure also to be here, join this session with Dr. Sievert, always a reference for us in Brazil and South America, and of the pioneers in all of these new developments, new technologies that you are using now in our current practice in our cath labs. Congratulations for your talk, very nice. And we are observing here the revolution that TAVR, TAVI is doing in the clinical practice. And we have outstanding results with the current device, like the last generations of Sapien, the last generation of Evolute. Now you are having the launching of Cortico in Brazil. And now in a few weeks, we're going to have this new system. And according to your presentation, probably the main characteristic is the increased radial force. That's going to be the niche of this technique, of this device, will be for calcified valves, and especially bicuspid valves. They have a lot of here in Brazil. But do you have any concern, because now, once TAVR is being more minimalist as possible, and we try to avoid pacemaker implantation as possible, like to do very high implantations with the core valve system or the Evolute system, using overlap techniques, or else with rapid pacing. So we put as high as possible. Do you think that this increased radial force will be an issue to use this Venus valve as like any other, like a workhorse valve for clinical practice?
Well, actually, as I mentioned in my talk, these 20% was less than the core valve had at that time. The average incidence of pacemaker need was about 30% in Europe, at least. So I think, no, the increased radial force does not mean that you need more pacemaker. And I mean, we all learn to the different implantation technique to implant this higher. And when you implant the venous valve high enough, you will not have any pacemaker need, at least not by the valve. I mean, we see the same thing with core valve. Since we implant the core valve high enough, we see, if we see pacemaker need, that is occurring due to the wire and not to the valve itself. So no, the increased radial force, to my understanding, does not increase the need for pacemaker. But we will hear in the next presentation about the results with the VenusA Plus, and I think this will be shown there as well. They also have a very low pacemaker rate.
Yeah, I totally agree with Professor Sievert's opinion. So, just the implantation of the pacemaker rate, I think just because of the implantation depth or just the strategy of the implantation. Yeah, maybe the oversized strategy, etc. Yeah, so just in our experience, the implantation, the pacemaker implantation rate is quite low, less than 10%, especially for bicuspid valve, because we tend to choose smaller one and put it higher enough.
This is the Hangzhou implantation technique developed for bicuspid valves, and I think you also use it in tricuspid valves. You basically implant the valve yes. of the left ventricle. So it's almost impossible to cross an AV block, at least not by the valve, because you are higher above the annulus, right?
I have a question.
Yes. For the design of the, I'm sorry.
Are you using the overlap cusp for this valve technique?
I didn't use it at that time. As I mentioned, we currently don't have the venous valve available, and so I don't know whether you use the cusp overlap technique in Hangzhou.
Yeah, some cases we will use the cusp overlap technique. Yeah, it depends on the operators. Yeah, in China, some centers they just use this in recent years. Yeah, just I think just in recent days. Yeah, so this is just the implantation technique.
So for core valve, we use it all the time. Yeah.
Márcio, do you have any comments about
so
this?
Go ahead, Dr. Liu, go ahead.
Yeah, so just for core valve right now, just there's no commercial use of the Evolut Pro in China. Just we used about 5 years ago for the core valve, the first generation core valve. We have some experience. Yeah, I think just the design is quite similar. Just the radial force is totally different. And for the design of the VenusA, so just for the bottom of the stent, they just have taped design, a little bit smaller of the bottom than the largest one. Yeah, so just from the company side, they want to just lower the pacemaker rate for the taped design.
Okay. Eduardo, do you have any comments or question?
Yes. Good morning, everyone. First of all, thank you for the 4Valve team for this kind of invitation. It's a pleasure for me. It's just a really rapid question for Professor Sievert. Considering this impressive radial opening force valve, there is a specific recommendation for predilation to be mandatory or not?
Well, for a regular valve, which has average calcium load, there's no need to predilate. But when you have these heavily calcified valves, you always have to predilate. But that is not due to the valve, to the venous valve. It's due to the native valve, and that's indeed very important. So when you have this amount of calcium, and especially in bicuspid, I think you have to predilate always.
Okay.
And that's something we actually learned during these early days. And the cases I showed you are some of the early experience where sometimes we did not predilate enough. And then what happens is that the valves moves into the left ventricle during deployment.
Okay. Professor Sievert, a question about the future. Do you think that one day we will have a class effect of TAVRs? Or like the stents, for example, just to imagine the future. You think that one day, even a new valve like this one, we cannot repeat all the tests to see if it works or not, and we will have a class effect? You think it will be possible one day?
Oh, yeah, we already have that. I mean, the effects of the different valves, the results of the different valves are very much comparable. And they are just nuances like what we discussed here. So this is a valve which is especially good for calcified valves, but you also can use this as your workhorse. But that doesn't mean that you cannot use other valves in heavily calcified valves. You still can do that, but there are little nuances in the features of the valve which gives priority in one or the other situation.
Okay, great. Vinicius, I think that we need to move on.
Yes,
Dr. Liu has a flight. Is it? Dr. Liu.
Yes, Dr. Liu has a flight to catch, so I think let's go on. Márcio.
So, Pedro, I think that you can share the presentation of Dr. Liu. And Dr. Liu is from China and has a lot of experience with a valve. And Pedro is sharing, Dr. Liu. Okay, you can see the presentation.
Yes, I can see it. Okay, dear panelists, yeah, thank you very much for involving in the conference. Yeah, I'm really very happy to present our experience of the VenusA and the VenusA valve, especially in bicuspid aortic stenosis. Okay, next one. I don't have any disclosures. Next one. Yeah, so the bicuspid aortic valve is the most common congenital cardiac malformations, and it's related to the age. And the younger, the more frequent of the bicuspid aortic valve. And because of the difficult anatomy, so TAVR is not included in the RCT study in the just like the partner or the other studies. Next one. However, in the other registry or the real world, we have so many cases with bicuspid aortic valve. And next one. From the Everett Pro Low Risk Bicuspid study, they included 150 cases, and we can see the result right here is quite good. All-cause mortality or disabling stroke just about 1.3%, and all-cause mortality less than 1%. And we can see there's not so many complications. Yeah, the result is quite good. So, however, the permanent pacemaker implantation rate is about 15%. Okay, next one. And for another TVT registry, we can see right here the sample size is quite large. Yeah, they just included over 90,000 patients, and compared with over 2,000 cases bicuspid and tricuspid aortic stenosis. And then next one. And we can see for the endpoint of the mortality and stroke quite similar. So however, so maybe just for the complications, so maybe a little bit higher in bicuspid aortic valve group. Next one. So just for the guideline from 2017 to 2020, yeah, we can see there's some change. So because so many experience from the registry and the real world experience, and in patient with bicuspid aortic stenosis and symptomatic, and the TAVR may be considered as an alternative to SAVR after consideration of patient-specific procedural risks, values, trade-offs, and preferences. Yeah, so this sometimes changes to the clinical relevance. Next one. So, however, as we know, there are some complications of bicuspid because the anatomy is complicated. So we can see right here, if there's a raphe, especially the calcified raphe, and the complication rate is a little bit higher than the other anatomies. And the all-cause mortality in this subgroup is pretty higher than the other subgroups. Okay, next one. And just like Professor Sievert just mentioned, the bicuspid aortic stenosis is very special in China because of the prevalence just in the TAVR population is pretty higher than the Western populations. So from the VenusA trial and from our center, it said, yeah, the results is quite similar. Next one. And also, the calcification is quite higher in China than the Los Angeles population published by Hassan Harvey. Next one. So how to conquer the problem of the aortic stenosis with the bicuspid? So we can just have two ways. The first one, we have to use the special device, and the other one, just for the implantation technique. Okay, so we already got the information from Professor Sievert's slides. The VenusA, just a very special higher radial force design, especially for bicuspid aortic stenosis, and the severe calcification. Next one. And from the first clinical trial, yeah, it has started at about 2012, and Professor Sievert gave us so many contributions on the TAVR procedure in China. And there are 4 centers involved in the registry. Next one. And the result from the 100 cases is quite good. Next one. Next one. Yeah, from 1 year and a 5 year result, we can see the all-cause mortality. Yeah, I think is quite similar with the other devices, and the pacemaker rate about 20%. I think this is just quite similar with the co-valve. I think right now, so maybe much lower because of the implantation depth strategy changes. Next one. And the gradient and the hemodynamic, yeah, can quite stable through 5 years. Okay, next one. So however, VenusA is the first generation, and because it's non-retrievable or non-representable, so it's quite challenging for the physicians to perform the procedure. Yeah. So our team worked with Venus Meditech together to develop the second generation and to make this, because it's quite difficult to develop the delivery system. So because the high radial force of the VenusA, because the VenusA valve is the same. Yeah, the higher radial force, yeah, the difficult of the delivery system is quite difficult. Yeah. And we started to design at 2017, and we started the film study at November 2017, and we already finished the pre-market clinical trial at 2019 and already approved by the NMPA last year. And right now we can commercially use in China nationwide. Okay, next one. Yeah, compared with VenusA registry, so we can see the basic baseline are quite similar. Okay, next one. So, however, we can see right here, the bicuspid aortic valve is quite high in VenusA Plus group. So, at that time, only VenusA Plus is the retrievable, just in China, the clinical trial. So, all of the centers involved in the clinical trial, they just include all of the difficult cases in this study. Yeah. Okay, next one.
Ladies and gentlemen, may I have your attention, please?
So compared with the VenusA valve, we can see right here, the all-cause mortality is the same. However, we can see right here, there's no myocardial infarction or conversion to TAVR. And the pacemaker rate is much lower in VenusA Plus because we can change the position. Yeah, we can just implant much higher than the VenusA valve. So combined, the endpoint is much lower than the VenusA valve. So, okay, next one. And for the hemodynamic, so because of high radial force, when we use the retrievable, so we just worry about maybe it will destroy the stent. Yeah, so sometimes we just worry about that it will affect the hemodynamics. So however, we can see VenusA and VenusA Plus valve, the hemodynamic is quite similar. Yeah. Okay, next one. So right now, we just for our daily use, we will not, for our interventional cardiologists, we don't want to use the first generation. We want to use the second generation. Give us more chance. Yeah, today I just proctored VenusA valve, the VenusA Plus valve in another center in China. Yeah, so because of the bicuspid, and the anatomy is quite large, and we retrieve just 2 times and put a very good position. Yeah, and we are very comfortable for the procedure. And then for the second part, I think the device is one part. And the second one, we have to change some of the implantation depths. Yeah, so Professor Wang, my boss, developed the Hangzhou solution for bicuspid patients. So because for the co-valve, for the tricuspid, and we usually use the annular sizing strategy. So however, for the bicuspid, simple annular sizing, simple annular. So sometimes we can't open the simple annular annular structure. Yeah, we can see during the balloon aortic valvular plasty, sometimes we can see the very severe waste there. Yeah, so that's why, and then we can open the supraannular structure, and then we have to choose smaller size of the valve. We have to downsize, and we can just implant a little bit higher for the valve, and we name it Hangzhou solution, and we published this in CCI 2018. So, however, at that time we usually use smaller one, just stepwise balloon sizing, use 20, 23, yeah, and this is not so convenient in the clinical practice. Okay, next one. Next one. And then last year in 2019, and we modified the Hangzhou solution for bicuspid aortic valve. Yeah, according to the annulus diameter from 20 to 29, and we will use different balloon and 20 or 23 or 26, and then we will select the correct size of the VenusA or VenusA plus valve. Yeah, we usually just if there's severe waste and no regurgitation, and then we will down one size. If there's no waste or there's some regurgitation, then we will use the annular size for the valve, no downsize. Yeah. Okay, next one. And the results of the modified solution is quite good. And then right now, we just started the RCT study we just called the Hangzhou solution, and compared with the supraannular sizing strategy to the annular sizing strategy. And we started at April this year. Next one. And here I will show two cases. And this is the 69 years old lady. And when we can see right here, the patient is the patient is type 0 bicuspid aortic valve, and the leaflet is calcified and thickening right here. And the primary derived diameter is over 23.3 millimeter. Okay, next one. Yeah, according to our strategy, and we use 23 ZMAD, and we can see. Can you click it? Oh, I'm sorry. Go back. The video have some problem. And we can see during the BAV, we can see there's waste with no leakage. So then, because this is a Hangzhou solution group, then we down one size. We choose 26 VenusA plus. Next one. The video can work or not?
Pedro, click on the play, please, on the video. Looking for.
Okay, no problem.
Videos are not working. Sorry, Dr. Liu.
Okay, no problem. And the position of the VenusA valve is quite good, and there's no leakage, and the gradient is quite good. Yeah, so down one size for the Hangzhou solution group is quite good. It works quite well. Okay, next one. And this is another case. Yeah, calcified type 0 case from the 82 years old gentleman. And next one. And the diameter is about 24 of this case. So because of the diameter between 23 to 26, and we still use 23 ZMAD. And because of the annulus based sizing strategy from the control group, and we use the 29 VenusA plus. Next one. And during the procedure, so because this is the annular sizing strategy, and it's not easy for us to control the depth. Yeah, so, and we just for this one, we retrieve and reposition once, And then at last, we just release it. So however, we can see right here, because the pigtail is the bottom of the annulus, yeah, the depth is quite low. Yeah, and we can see the complete LBBB in this patient. Yeah, so if the patient included in the Hangzhou solution group, and we will down one size for this patient, 26 will be okay for this patient. Yeah, so because this is the RCT study, and we have to use 29. Yeah, so and we will see the results of the Hangzhou solution RCT study, and the VenusA Plus works quite well in the type 0 or type 1 bicuspid aortic valve, especially for the calcified cases, and we need higher radial force. And next one. So in conclusion, and as the percentage of the bicuspid aortic stenosis is higher in Chinese TAVR population, and we don't know for the general population, is there some difference or not? We don't know about that because we don't have that data. And bicuspid aortic stenosis with severe calcification makes TAVR procedure much more complicated. And the benefits, yeah, there's so many benefits of VenusA and VenusA valve for the bicuspid aortic stenosis, especially because of the higher radial force. And the Hangzhou solution is feasible for patients with bicuspid aortic stenosis. However, and we need RCT results. Okay, that's all. Thank you. Thank you very much.
Thank you so much, Dr. Liu, for this great presentation with thought cases. I'm gonna share a question from the audience, and then I'm gonna move to our panelists. They are asking if you can do commissural alignment with these prostheses for future coronary access.
For VenusA valve, right now we can't do that. Yeah, Professor Sievert, is that possible? We just make a little bit change for the marker. Is that possible? We can just like even the Pro, and we can use the commercial. Is that possible?
I don't know. I mean, we have never tried this with the venous valve, and actually we don't do this for the core valve. And over the years, I mean, we do core valve since it emerged. Actually, everybody is talking about it, but we never had problems to get access to the coronaries. It's actually you have to use a different technique. So sometimes the EBU catheters don't work, so the conventional JR4 works better. But actually, you have always good access, and sometimes you have even more stable position of the guide. So I'm not really looking at this anymore. But Liu, I have another question to you. You mentioned that you prefer the VenusA Plus valve because it's retrievable, and I can understand that. But the question here also for the audience is, of course, don't you see a place for the conventional VenusA valve at this time? Because in South America, the A Plus is not approved yet.
Yes.
And so do you think they should wait until the A Plus becomes available, or don't you think that the regular VenusA valve is a good solution for a standard case? I mean, it would maybe not good for a very complex horizontal aortic arch or something like. But I think for a regular straightforward case, I think it's a good valve, and as I understand it, will also be cheaper, which is not only a problem. It's not your problem in China, but in Europe and South America, in Germany and South America, cost is an issue. And when you have a patient who cannot afford another valve and has a straightforward anatomy, before you let him die, I would actually like to use the VenusA valve in that situation. I would not wait for the A Plus valve.
Yeah, I agree. I think we don't need to wait for VenusA Plus for the procedure. So, you know, I think, over 95%. Yeah, so maybe over 90%, we don't need you to use the retrievable. We can just implant it very quite well. Yeah, the VenusA Plus just give us maybe just one more chance to repositioning or retrievable. Yeah, so, you know, because right now we have the opportunity to use it. Yeah, so just over 80 years, we just used the first generation, and the results quite good.
And also, I mean, the Sapien valve, the Indisch Mai valve, the Accurate Neo, all of them are not retrievable, really. So, I mean, it's nice to have that additional feature, but that doesn't mean that you cannot use it. Yeah, I think we agree on that.
Yeah, I agree. Yes.
Eduardo, do you have any question for Dr. Liu? What do you think about this hand-zoom solution? I think it's a very nice approach to the bicuspid valve,
Yes, Márcio, I totally agree. Professor Liu, just some questions. First of all, just to clarify any doubts, the VenusA Plus is the same valve with a new delivery system. It is? Is it true?
Yeah.
Okay. And what's the maximum?
The valve is the same. Yeah.
Okay. And what's the maximum annulus diameter or perimeter, the maximum range to treat with this valve?
I think it depends the anatomy. So for me, just for bicuspid aortic valve, 35 millimeter, I can use 29 VenusA valve. Because the simple annular structure is quite complicated.
Yes.
Yeah, we just use 23 or 25 balloon, and we can see severe waste and no regurgitation. Yeah. So 29 is big enough. Yeah. So for the tricuspid,
the largest size is 32, right? That means you can go up to an annulus diameter of 40.
For the valve, 32 is a big one. So just for the anatomy of the aortic root, it depends. Yeah.
Do you recommend in this first generation deploy with rapid pacing or not? Is it necessary to deploy this first generation with rapid pacing or?
Yes, I agree. Yeah.
So rapid pacing is a good option. But what we do with the core valve, and I think we also did this in the Chinese days with the venous valve, we pace about 120, 140. We do not do really rapid pacing with 200. That's something we do in patients with aortic insufficiency, or when we see during the insertion of the delivery system that there's a lot of movement, then we pace faster. But actually 120, 140, I think is enough.
Is enough, yes, I agree. I fully agree. Rogério, any question?
Yes, congrats for your talk, Dr. Liu. Listening to your presentation, I think that maybe we can do some step backs again, because we have all learned in the past years that CT is mandatory for device selection. So I'll always trust I'm going to select by the side of the valve, the position of that I will start to deliver the valve according to the CT data and CT interpretation. And according to the Chinese presentation, you change it a little bit. So as I can see, you trust much more in the pre-dilation balloon size than in the data that the CT will show to you. No, you have to use a 26, you have to use a 29, because size is always a question, is always a challenging in bicuspid anatomies, especially the ones that are not tubular, the shapes a little bit, the very elliptic valves. So do you really think that you can be less CT dependent when you use this approach that you are suggesting us to trust 100% in the predilation information? Because I'm today I'm completely CT dependent to drive all my TAVR thoughts.
Yeah, that's quite same in our center. Yeah, all of them. Yeah, we will use CT guided, especially for the emergent case. Yeah, for the emergent case, we will 3D echo, and we will use the balloon sizing together to decide the valve size. Yeah, we rely on the CT 100%.
Yeah, but you say, I mean, this was a very interesting question. So you said you always do CT, and I know that, but you don't rely on the measurements of CT because you do then balloon sizing and then go for smaller anyway. So you could also do just a regular transthoracic echo, get an idea, okay, this is maybe 29 millimeter annulus, and then you downsize with your balloon to 23. You see whether you have complete seal, and then you implant the 23 or 26 millimeters. So you don't really look, I mean, you look at the CT, I know that, but you don't have to with your technique.
Yeah, so we can combine with them. The different techniques together, CT and balloon sizing together.
Dr. Liu is analyzing all the CTs in his center, so this is kind of his baby. He cannot think about doing something without CT. That's his situation now.
Exactly. Vinicius?
We have a question from the audience for Dr. Sievert, not actually about the VenusA valve, and they are asking if you recommend any tips of sizing in bicuspid valve, and what percentage does you use in self-expanding and balloon-expanding bicuspid valves? What's your approach about bicuspid valves?
Well, initially when we started doing bicuspid valves, we always used the annulus sizing, and nowadays we are following partially the strategy of Dr. Liu and his colleagues. So we tend to downsize, but it's not that strict. So I would not go for a 23 millimeter valve in a 29 millimeter annulus. But for example, to stay with this example, if the annulus is 29, then we go down to 26, something like that. So it's one size, sometimes some size. But if it is a borderline, then we go for the smaller size. But we do not downsize more than one size.
Okay. If you can share with us about the femoral approach, about the pushability of the device, how does it go through the aortic, because you have so much experience with them. Can you tell to
yeah, that's actually a very good question. Because of the increased radial force, the entire system is more stiff than what you use with the core valve. And sometimes we had to use, I think that is still the case with the A+ generation, we very often have to use stiffer wires. So actually when the regular Amplatz extra stiff or super stiff is not sufficient, then we go for a Lunderquist wire, which gives excellent stability and trackability. There's only one thing you have to keep in mind, that this wire is not really designed for TAVR, so that means the distal tip is kind of stiff. So you have to be very careful to keep it into position in order to avoid LV perforation. We never had one, but this is just something you have to keep in mind. So the Lunderquist actually helps a lot in these cases with this particular valve. You, how often do you use Lunderquist compared to Amplatz extra stiff?
We use Lunderquist for all evolute, probably all, not small, without the small ventricular, but for evolute, we use a lot of Lunderquist.
Yeah. Liu, how is this in China? How often do you use Lunderquist compared to Amplatz extra stiff, or is muted?
Yeah, we don't have so many choices of the stiff wire. Yeah, so for VenusA valve, we usually use the Lunderquist. Yeah, I think 95% of them.
Yeah.
Okay. Vinicius, I think that we are running to the end, and we can hear the last message from the panelists and from Professor Sievert and Dr. Liu. I think that we can start with Rogério. Rogério, any final comments, final question?
No, I think that's congrats again from the idea. Congrats to Dr. Liu and Dr. Sievert. I think that it's always nice to learn and to have some different options, especially in these emerging countries like Brazil. Maybe price will be down here and could be another option. And one brief question that I have about the speed of when you start to deliver, because we learned something for core valve, we move it from evolute, and now with Portico, you have another strategy. How fast you deploy the valve?
Good question.
Good question. So when we started this, we deployed it fast. Actually, that's what we did with core valve at that time. And as I mentioned earlier, this valve is very stable. So you can do this fast. It's not moving a lot. I don't know, Dr. Liu, have you changed that strategy? Are you doing this with the core valve? Now we do this slow implantation technique. So we let the valve flare and wait. Is that what you do with the current generation as well in China?
Yes, I totally agree. Yeah, I like the very low implantation, slowly by slowly. Yeah, give time to expand. Yeah.
Okay.
Eduardo, any final comments?
No, just congrats everyone for the lectures. Thank you once again to be here. We are moving to a new time with every 6 months I believe here in Brazil we have a new valve. So it's natural to learn with the old valve to the new valve. So the discussions was really great. I learned a lot here. Thank you once again for everyone.
Great. Okay, Márcio, please, if you can close the session.
I prefer talk in the end. I would like to hear Dr. Liu. Final comments, Dr. Liu?
I think a final comment from Professor Sievert.
Thank you very much involving us, and I'm looking forward to a great start of this valve in South America. What I have seen in China, it was a fantastic journey, and I think you will have the same thing with this valve and also with other valves in South America.
Oh, great.
Thank you very much.
So, to my last words, I have tried to do some words in Chinese, but I don't know if it's one. Then I would like to say to my friends from China, Ni hao, huani lai bashi.
Good in Chinese. Very good. Yes, very good. 谢谢大家，谢谢。再见。
Thank you guys.
Thank you so much. Bye bye.
Okay. Bye bye. 再见。
Bye.